All right, we're going to go through a couple of endocrine questions. Um, so I'll kind of present the question. You can pause your screen, think about it, and then I'll go through the answer, and then we'll go through some of the wrong answers as well. All right, 32-year-old woman presents with fatigue, weight gain of over 15 pounds over 6 months, constipation and cold intolerance. She reports her hair has become coarse and brittle. On exam, she has a heart rate of 56, delayed relaxation of deep tendon reflexes, and mildly enlarged non-tender thyroid gland. She has a TSH of 18.2, which is elevated, and a free T4 of 0.5, which is low. She is positive for anti-thyroid peroxidase antibodies. Now, my question is, which of the following best describes the pathophys of this patient's condition? So pause your screen, take a second to think about it, and we'll go through it. So right answer here is going to be B, lymphocyte-mediated destruction of the thyroid follicular cells. So this patient has Hashimoto's, okay? Hashimoto's is also called lymphocytic thyroiditis or lymphocytic Hashimoto's. You'll see it a couple of different ways that will be described, but all it is it's lymphocytic, so T-cell mediated destruction of the thyroid follicular cells. So when we have destruction of the follicular cells themselves, we have a hard time forming thyroglobulin. We have a hard time forming MIT and DIT. And then we have a hard time releasing T4 and ultimately converting it to T3. So we get a low level of free T4 and then T3. Remember that T4 is converted by 5' deiodinase at the end organ tissues into T3, which is a more metabolically active hormone. Of course, in the thyroid itself, we do make some T3 that will get released as well, but the primary way we make T3 is with that conversion out in the periphery. So if there's low free T4 and T3, there's less negative feedback back up to the hypothalamus and to the anterior pituitary. So there's an increased level of TRH, thyroid releasing hormone, from the hypothalamus, and an increased level of TSH, thyroid stimulating hormone, from the anterior pituitary. So some of the other wrong answers, an activating TSH receptor mutation, that would be something like Graves' disease. Okay, we'll talk about that later. And iodine deficiency, yes, iodine deficiency absolutely can cause hypothyroidism, primary hypothyroidism, right? In terms of endocrine, when you think about a primary disorder, we think about the gland itself, the organ itself that's dysfunctional. So in primary hypothyroidism, it's a thyroid that's dysfunctional. So having a lack of iodine, then we can't convert it, or we can't combine it with tyrosine, right? Or we can't make our MIT, DIT, and then eventually our thyroid hormones. That absolutely can lead to primary hypothyroidism. The thing is in America, in other developed countries, you're very low likelihood of seeing that unless a patient has like a really restrictive diet. So it's usually almost the never the right answer on a board exam. And in real life as well, right? Obviously, if you've ruled out other things, start to consider it. This patient also has anti-thyroid peroxidase antibodies, which are fairly specific for Hashimoto's, okay? Remember, thyroid peroxidase is one of the key enzymes in the follicular cells of the thyroid that are important for making our thyroid hormones. A TSH secreting pituitary adenoma, well, let's think about that. If my pituitary was making too much TSH, it'd feed back, it would go down to the thyroid and would stimulate an increased production of T4, T3, right? So in that case, we would have what's called secondary hyperthyroidism, right? So there's an activating or there's a tumor in my anterior pituitary that's forming too much TSH, secreting too much TSH. And so now we're feeding to the thyroid to tell it, hey, make more T4. So in this case, your TSH would either be elevated or within normal limits, and the T4, T3 would be elevated. So that's now what we're seeing here. So with regards to that, you would see, right, the key with that is when I said that the TSH could be normal, what you'd have to think about is if the T4 and T3 were quite elevated, right, in a normal person, normal physiology, that would feed back and the TSH should be undetectable, right? So if the TSH is within normal limits, but the T4 is like super freaking high, you're like, that's kind of weird there. That tells me that the anterior pituitary is working a little bit too hard, right? And we're not able to fully feed back. Sorry, I'm not sure what's happening with the PowerPoint here. It's not sharing. There you go. And then excess iodide, right? So that's the Wolff-Chaikoff effect. So occasionally we can use this to our advantage. We give the patient an excess amount of iodide. That iodine then feeds back, and the thyroid's like, yo, we're good on all the iodine, right? So we don't need to make any more thyroid hormone. So it shuts it down for a little bit. It only works for a short period of time, but that's obviously not what's going on here, right? Um, Other things I want you to know about Hashimoto's, right? I put it on here. It's associated with Down syndrome, Turner syndrome, and other autoimmune conditions, right? If you come to any of my lectures, I've talked a lot about Hashimoto's with type 1 diabetes, celiac disease, vitiligo, pernicious anemia, and then Addison's disease, right? They like to run together. Um, Other things with Hashimoto's, right? Our thyroid hormones are really important for stimulating the uptake of cholesterol back into the liver. So a lot of the times these patients with Hashimoto's can have elevated cholesterol. I've seen a lot of questions on that. Treatment, right? Treatment is going to be give them thyroid replacement, right? So levothyroxine. Um, and then there's something I wrote in here called myxedema coma, more of an advanced step 2, step 3 kind of question. But myxedema coma is just really, really bad hypothyroidism, right? So the patient's going to have really significant bradycardia, respiratory depression, like their reflexes probably aren't going to work, right? They're going to be hypoglycemic, they're going to be really cold. And then, of course, myxedema coma, they're probably going to be in a coma, right? Um, so all things to consider. Again, that's more of an advanced concept there. The last thing I'll mention is make sure you look out for neonates who have hypothyroidism, right? So maybe mom has a history of hypothyroidism, right? And she wasn't taking any medications during pregnancy, or the most common cause of hypothyroidism in neonates is going to be thyroid dysgenesis. The thyroid just is not made correctly. Oftentimes, these kids will be totally normal the first week or two of life because if mom has a functioning thyroid, the TSH and T4 are able to cross the placenta. So baby is supplied with a little bit of thyroid hormone and TSH for a little bit of their first week or two of life. But then all of a sudden the baby is going to start deteriorating pretty quick, right? They're going to have a hard time feeding. They're going to be irritable. They're going to be hypotonic, right? Really floppy baby. And then the thing we really worry about is the neurodevelopment, right? Without proper thyroid hormone, this baby is not going to be able to develop neurally, right? And this is like very, very detrimental. So if we don't get thyroid replacement hormone, usually within the first month, the prognosis is very poor. All right. Next question. 26-year-old woman presents with palpitations, weight loss of 12 pounds, heat intolerance, and diarrhea for 3 months. She is anxious and tremulous on exam. Heart rate's 112. She has bilateral exophthalmos, a diffusely enlarged smooth thyroid, and pretibular myxedema. Her TSH is less than 0.1. Free T4 is 4.2, which is elevated, and thyroid stimulating immunoglobulins are elevated. Which of the following cell surface receptors do TSIs primarily target? There are your answers. So take a second, pause your screen, and think about it. And really, no surprise here, but maybe you haven't thought about it. But thyroid stimulating immunoglobulins stimulate the thyroid stimulating hormone receptor, right? Or the TSH receptor. So really, all that happens is here, right? I kind of described it here, but we have the autoantibodies in Graves' disease, either TSIs or TRABs, right? TRABs. The TSIs are thyroid stimulating immunoglobulins, so we're only going to test for the hormone or the antibodies that are stimulating the thyroid. The TRABs will test for any hormone that's binding to the thyroid receptors. So whether those be inactivating, neutral, or activating, okay? So you might see it either way, but they're going to activate the GS protein coupled TSH receptors on the thyroid follicular cells that mimics TSH. We increase CAMP, and then we get continuous T3, T4 synthesis, even without or even despite that pituitary feedback, because this T4, T3 are going to be elevated. They're going to feed back. They're going to tell the anterior pituitary and hypothalamus, I don't need any more TRH. I don't need any more TSH. So this patient's endogenous TSH is going to be very low, maybe even undetectable. But those TSIs, those TRABs are still going to feed back and still stimulate the thyroid hormone. So they're still going to make T3 and T4 despite having very, very low levels of endogenous TSH. We already talked about TPO, right? That's a marker of usually Hashimoto's. The sodium iodide transporter is really important for getting iodide into the thyroid hormone, but it's not implicated in Graves'. Thyroglobulin becomes really important, right? Because thyroglobulin is one of the carrier proteins for the thyroid hormones within the follicular cells themselves. I care about thyroglobulin in papillary thyroid carcinoma. So papillary thyroid carcinoma is the most common form of thyroid cancer. It's classically younger females. So, like a 19-year-old female comes in with a mass and she's not hyperthyroid, she's not hypothyroid. You do your workup, right? That's more of a step two concept, how you work this patient up. You do a fine needle aspiration and then you end up diagnosing her with papillary thyroid carcinoma. Usually the treatment is bilateral thyroidectomy. Okay. Take out the whole thyroid. You put her on levothyroxine for the rest of her life. What we do then is we do regular follow-ups, usually every couple months, every 6 to 12 months, as you get further down the road. And one of the things we do is we test for thyroglobulin. The only way a patient makes thyroglobulin is if they have functioning thyroid tissue somewhere in their body, right? So in this case, hey, if we took out both lobes of the thyroid, her thyroglobulin should be undetectable. So if all of a sudden we start seeing the thyroglobulin levels start rising, we're like, oh crap, did we miss some of the cancer, right? And that's how we kind of gauge, that's one of the ways we gauge, is the cancer reoccurring. It's the same idea with medullary thyroid carcinoma, which is the type of thyroid cancer. It can present on its own, or it can present in MEN2A or 2B. And so medullary thyroid carcinoma tends to secrete calcitonin. So we can check, again, for these patients, we can check their calcitonin. And then the iodide thyroid, or the thyroidine deadenase, or the 5' deadenase, we already talked about, converts T4 to T3. Other things about Graves, you can have the exophthalmos, or the I can't even say it, but like the proptosis, right? The proptosis is because these TSIs will stimulate fibroblasts in the eyes, and those fibroblasts will secrete glycosaminoglycans, and that it causes fibrosis and pushes the eyes forward. To treat that, right, we can give them steroids, and then there's a new drug called teprotumumab, which is an antibody against those fibroblasts. Um, Other things about Graves' disease, right? We can give the patient beta blockers, right? Beta blockers are going to be really good to stop the downstream effects of these thyroid hormones, right? T4 and T3 upregulate the sympathetic nervous system, or they sensitize our body to be more receptive to norepinephrine and epinephrine. So let's give them a beta blocker to stop some of those downstream effects. We can also give things like methimazole or PTU. So methimazole blocks thyroid peroxidase, and then PTU blocks thyroid peroxidase and 5' deadenase. We tend to like methimazole better than PTU because PTU can cause fulminant liver failure, okay? Both drugs can cause what's called agranulocytosis, um, which is a lack of neutrophils, right? Which can be very, very deadly, right, if the patient gets an infection. But methimazole tends to be better tolerated. Um, with regards to the only times we really ever give PTU is, of course, if a patient has some sort of problem taking methimazole. And then the other times would be first trimester of pregnancy. We like to use PTU because when methimazole is given in the first trimester of pregnancy, it can cause something what's called aplasia cutis, where the baby is born without fully formed skin. The other time we tend to give PTU is in thyroid storm, which is, again, it's kind of like the same thing as myxedema coma, but the opposite way, right? We're just way too overactivation of our thyroid. And we tend to like to give PTU in that situation because, again, it blocks thyroid peroxidase, but it also blocks that 5' deadenase, which is important for converting T4 to T3. So the thought is hey, if we dampen down the conversion of T3, which is the more metabolically active hormone, it might actually have better outcomes. The data doesn't really support that. It's one of the things we do for kind of no reason. Other drugs you give in thyroid storm, you'll give propanolol, right? And then we can give steroids as well. And propanolol and steroids both also decrease conversion of T4 to T3 via blocking that thyroid peroxidase. And then you can also give things like potassium iodide as well. I think those are the big things I wanted to say about that. All right. 45-year-old man is evaluated for hypertension, so his blood pressure is 168 over 102. He's refractory to 3 antihypertensives. He also has muscle weakness and cramps. His sodium's a little bit elevated. His potassium's low. Bicarb's elevated. His plasma renin activity is low. A CT scan shows a 2.2 centimeter left adrenal adenoma. Which of the following best explains the hypokalemia in this patient? So pause your screen and consider, and then we'll discuss. All right. So this would be excess aldosterone is stimulating the principal cells, the sodium, potassium, ATPase, and the collecting duct. So this patient has what we call refractory hypertension, right? By definition, refractory hypertension or resistant hypertension is when the patient is on 3 different hypertensives, with one of them being a diuretic, and their blood pressure still remains elevated. Okay. The big things I want you to consider with a patient who has refractory hypertension are going to be, one, are they actually properly taking their medications? Of course, rule that out. And then the next would be the more common causes, which would be things like renal artery stenosis, fibromuscular dysplasia. Um, so renal artery stenosis would be your 65-year-old male with hyperlipidemia, hypertension, diabetes, etc. And then fibromuscular dysplasia tends to be more younger females with the medial dysplasia, right, of their vessels. We can impact the renal arteries, the mesenteric arteries, the carotid arteries, right? Um, and so those will make up the vast majority, 80-90% of your resistant hypertension. But then about the other 10%, you can start considering these endocrine disorders. And there's a couple different endocrine disorders that you can consider. Conn syndrome, or primary hyperaldosteronism, is going to be the most common cause. But then we also have something called reninoma, which is a JG cell tumor that's secreting renin, obviously. And you have things like syndrome of apparent mineralocorticoid excess, where you have a dysfunctional 11-beta hydroxysteroid dehydrogenase, or the patient was taking just a crap ton of black licorice, which has glycyrrhetinic acid, which inhibits that enzyme. And so to briefly talk about that one, in so normally when we make cortisol, right, from the zona fasciculata, it does a number of things, right? And cortisol will be, a discussion on its own point. I'll do a separate question on adrenal stuff. But when cortisol becomes elevated, one of the things it can do is it can go down to the kidney. In really high amounts, cortisol can have mineralocorticoid activity, just like aldosterone. The thing is our kidney has this beautiful enzyme called 11-beta hydroxysteroid dehydrogenase 2 that converts cortisol into cortisone. Cortisone has no mineralocorticoid activity. Okay, so our kidney is protecting, and it's saying, hey, the only mineralocorticoid that's going to work here is aldosterone. Okay, cortisol, you can't act like a mineralocorticoid. The problem is the patient has a genetic mutation, or they just ate a ton of black licorice and that enzyme gets inhibited. Well, guess what? Cortisol can go down to the principal cells and start acting like a mineralocorticoid. And what do mineralocorticoids do at the level of the kidney? They cause increased sodium and water reabsorption, and they kick out potassium and H+. So you'll see all of a sudden, hey, the patient's blood pressure is going to start rising. They're going to have resistant hypertension. They're going to have hypokalemia and metabolic acidosis, a non-anion gap metabolic acidosis. So their sodium minus bicarb plus chloride will be, 12 or less, right? So that's a non-anion gap metabolic acidosis. And so then you'll see, and you'll go down your list. Are they taking their medications? Yes. You'll do CT angiogram or Doppler ultrasound of their abdomen, and you'll see there's no renal artery stenosis, there's no fibromuscular dysplasia. You can do other testing if you want to. You can test for pheochromocytoma with urinary metanephrine, serum metanephrines, and you can test then their renin plasma, renin aldosterone plasma levels. And renin will be low, and guess what? So will aldosterone. And you're like, that's weird. I would have expected their aldosterone to be elevated, given this resistant hypertension and then the hypokalemia metabolic acidosis. The thing is because cortisol is acting like a mineralocorticoid, we're reabsorbing more water, we're feeding back, and then that increased blood pressure to the juxtaglomerular cells is telling the JG cells, hey, we have enough blood pressure, right? We don't need to activate the renin-angiotensin system. So renin's low, Ang1, Ang2, aldosterone are all low, right? So syndrome of apparent mineralocorticoid excess. This patient has Conn syndrome, right, which is a tumor, either unilateral or bilateral, of their adrenal glands that's secreting too much aldosterone, right? And so it's going to do everything we just talked about, right? It's going to keep sodium in water, kick out potassium and H+. All right, I think those are the big things. You do not, for step one, you do not really need to know how to treat this. If it's bilateral, you obviously don't want to surgically remove both adrenal glands, right? We can put the patient into adrenal crisis or adrenal insufficiency. So we can give drugs like spironolactone or eplerenone, which are mineralocorticoid antagonists. Spironolactone is more potent than eplerenone at blocking the mineralocorticoid receptors, but spironolactone also inhibits androgen synthesis, which can lead to symptoms like gynecomastia, which are usually, patients don't want to have that if you're a male. But then eplerenone, right, doesn't have those anti-androgen effects. It's a little bit less potent, and it's also a lot more expensive. But if the patient has unilateral Conn syndrome, we can just remove the one adrenal gland, and that usually takes care of the work there. All right. And then I'll tell you the workup for Conn syndrome is a step 2 concept, not step 1. So don't worry about that. 55-year-old woman with a history of hypertension and type 2 diabetes is brought to the ER for confusion. She takes metformin, lisinopril, and recently started a new medication for weight loss. Her plasma glucose is 42. She has diaphoresis, tremor, and tachycardia. Her husband states she accidentally took double her dose of medication this morning on exam. This morning. On exam, the patient is oriented to person only. A sulfonylurea was identified as a likely culprit. What is the mechanism by which sulfonylureas cause hypoglycemia? So pause your screen and consider. So sulfonylureas block the ATP-sensitive potassium channel in pancreatic beta cells, right? So insulin is produced in the pancreatic beta cells, right? The mechanism is we have these sodium-potassium channels, and then we block the potassium channels, right? And as the potassium channels block, potassium builds up inside the cell. It causes an increased charge inside the cell. We eventually reach threshold and we stimulate an action potential. That action potential triggers the opening of calcium channels. Okay, so calcium floods in, and then calcium causes calcium-mediated exocytosis of insulin, and it gets removed from the pancreatic beta cells. When insulin is made endogenously in our pancreatic beta cells, it's packaged with proinsulin and C-peptide. So normally one of the things we can do is we can check the levels of C-peptide and insulin, and they're usually in about a 1-to-1 ratio, and that'll tell us, hey, this is true endogenous insulin. So when the patient is taking sulfonylureas, we're actually stimulating the production of endogenous insulin. The sulfonylureas block that potassium channel, so it's stimulating us to reach threshold faster, the calcium-mediated exocytosis faster, and increase more amount of insulin, right? So in a patient who's taking sulfonylurea, their elevated endogenous insulin is going to be high, and so is their C-peptide and proinsulin. That would be the same as if the patient had an insulinoma, a tumor of the pancreatic beta cell that's secreting too much insulin. So how do you tell them apart, right? The difference, we'll talk about at my endocrine lecture if you guys come to that. The difference, it takes a little bit of time. You got to do a 72-hour fast. You got to check a few more labs. But one of the things we can do is we can just do a urine screen for sulfonylureas. We have a pretty good urine test for that. But this is opposed to someone who's taking exogenous insulin, okay? And so if the patient's taking exogenous insulin, that exogenous insulin is not packaged with pre-pro insulin and is not packaged with C-peptide. So the pro-insulin and C-peptide would be low, but insulin would be high, right, if we tested for it. So that's one of the ways we can tell apart. And of course, insulin, right, an insulinoma is a pancreatic tumor, so that could be part of MEN1 syndrome, right? So MEN1 is pituitary, pancreas, parathyroid, usually together, right? That's a menin gene mutation, which is a tumor oncogene, whereas MEN2A and 2B is a RET proto-oncogene that is mutated, right? And MEN2s have two things in common: medullary thyroid carcinoma and pheochromocytoma. Then the 2A has parathyroid as a third little portion of it, right? And the way I remember that is 2A, parathyroid has two A's in it, right? And then the 2B, the kind of third component is your marfanoid habitus, mucosal neuromas, and intestinal gangliomas, things along those lines. So when a patient has a pretty significant hypoglycemia, if they're able to eat, right, we can give them oral dextrose or oral glucose. If they're pretty significantly impaired, if we have an IV in them, we can give them IV dextrose. If we don't have a way to get an IV into them, we can do intramuscular glucagon, which is the exact opposite hormone of insulin, and will stimulate gluconeogenesis and increase that blood glucose. All right, and then remember Whipple's triad, right? So are going to be the patient has documented hypoglycemia. They have signs and symptoms of hypoglycemia: tremor, diaphoresis, tachycardia, potentially seizures, right? Sorry about this PowerPoint. I don't know what's going on. all the things we kind of just discussed in this patient. And then they have they have a reversal of their hypoglycemia by giving them dextrose, right? That's Whipple's triad. All right. 38-year-old man presents with episodic headache, palpitations, diaphoresis. His attacks last 15 to 20 minutes and are precipitated by exercise and straining. His blood pressure during an episode is 220 over 130. Between episodes, it's normal, 138 over 88. 24-hour urine shows markedly elevated metanephrines. Man, this thing. Shows markedly elevated metanephrines and VMA. CT of the abdomen reveals a 3.5 centimeter right adrenal mass. Which of the following is the most appropriate next step in management of this patient prior to surgical resection? So pause your screen and consider. So this patient surely has a pheochromocytoma based on his elevated urinary metanephrines. What we want to do is we want to initiate alpha blockade with phenoxybenzamine first, okay? So pheochromocytoma, right, when we think about your adrenal, we have the outer cortex, which is composed of the glomerulosa on the outside, which makes mineralocorticoids. The fasciculata, moving inward, makes your glucocorticoids. Reticularis on the innermost portion of the cortex makes androgen, and then inside is the medulla, which makes catecholamines, norepinephrine, epinephrine. With a pheochromocytoma, we have a tumor that's secreting too much of these catecholamines, primarily norepinephrine, and then gets converted to epinephrine via different enzymes. We also can have something called a ganglioma or ganglionoma, which is kind of a pheochromocytoma on the sympathetic chain as well, right? Pheochromocytoma tends to be far more common, and by themselves, they're not quite common, right? But with these elevated norepinephrine, epinephrine, these elevated catecholamines, they're going to cause all the symptoms of sympathetic overdrive, mydriasis, hypertension, tachycardia, sweating, tremors, etc., right? Headaches. What you want to do is you want to check serum or urinary metanephrines to confirm there's elevated portion of the byproducts of norepinephrine, epinephrine. Norepi and epi only stay in the circulation for a very short period of time, so it's very hard to test for them. So we check for their byproducts, the normetanephrine, metanephrine, or VMA as well. So once we confirm that, right, we can do a CT scan. We can find the tumor, CT scan of the abdomen. And then what we want to do is we don't want to take them right to surgery, okay? Because if we start cutting into that patient, that stress of the surgery is going to cause a huge amount of sympathetic overdrive, and their tumor is just going to dump all their catecholamines. Patient's blood pressure is going to be 300 over 200, and they will die. One way I've seen this asked in a question is they take a patient to surgery, they start cutting into them, and all of a sudden their blood pressure is so high, and they say, what's the most likely diagnosis? Well, this patient likely has a pheochromocytoma that we didn't know about, okay? So with regards to this, right, we want to give an alpha blocker before a beta blocker, right? If we give a beta blocker first, we're blocking all the beta receptors, and guess what? Norepinephrine likes to bind to the alpha receptors, and it will bind a little bit to the beta receptors. Epinephrine likes to bind to the beta receptors, and it will bind a little bit to the alpha receptors, right? So if we block all the beta receptors, this norepinephrine, epinephrine that's getting secreted from the tumor, they have no choice but to bind to the alpha receptors, right? And if they bind to the alpha 1, we're going to cause widespread vasoconstriction. Their blood pressure is going to go through the roof, and the patient will die. So what we do is we give alpha blockade first, okay? We usually do that for about 10 to 14 days, and then we reassess their blood pressure. If their blood pressure is still not under control, we can add on a beta blocker. If it's relatively under control, then it might be safe to go do surgery, okay? The other thing you want to remember about pheochromocytoma is, again, it can be associated with MEN2A or 2B. It's also associated with von Hippel-Lindau and NF1 syndrome as well. Those are other common syndromes that it tends to show up in. All right, those are the other ones, things I want to talk about. All right, 5-year-old boy is brought for evaluation of short stature. He's been growing at the third percentile for 2 years. His bone age is delayed by 2 years. Growth velocity has declined. Lab studies show low IGF-1 and low IGF-BP3. An arginine stimulation test fails to produce a rise in growth hormone above 10 nanograms per milliliter. MRI reveals a large suprasellar mass compressing the pituitary gland. IGF-1 mediates many of the growth-promoting effects of GH. Which of the following is a primary site of IGF-1 production in response to GH stimulation? Pause your screen and consider. So You didn't have to really read any of the vignette in this. My question was, where is IGF made, right? IGF-1 is made in the liver, okay? The growth hormone pathway is a little bit more complex than some of the other ones. When I think about what's made in my anterior hypothalamus or anterior pituitary, we have FSH and LH, my sex hormones. Okay, we have ACTH, which controls glucocorticoids, all right? We have TSH, right, which controls the thyroid. We have prolactin, which is tonically negatively inhibited by dopamine, right? And prolactin will stimulate lactation, right? And then we have things like GH, right? Growth hormone. Okay. So the way you can maybe you've heard about it, but flat pig, right? FSH, LH, ACTH, TSH, prolactin, and growth hormone. And then of course some of these have things coming from the hypothalamus that stimulate them, right? So GnRH is what stimulates FSH, LH, right? CRH is what stimulates ACTH. TRH is what stimulates TSH, right? Dopamine is tonically inhibited by prolactin is tonically inhibited by dopamine, and then GH is activated by GHRH, growth hormone releasing hormone. So growth hormone releasing hormone comes from the hypothalamus, goes to the anterior pituitary, stimulates growth hormone. Growth hormone goes down to the liver and stimulates IGF-1. Growth hormone does a bunch on its own, but it's the IGF-1 that actually causes linear growth. And then IGF-1 and growth hormone feedback and shut down the feedback loop. But then there's an extra wrench in the system where somatostatin, which is made from the hypothalamus, can also feedback and shut down the growth hormone loop. So in this patient, normally giving an arginine stimulation can trigger an increased amount in the growth hormone. In this case, it didn't work, right? So we can diagnose the patient as having a low amount of growth hormone. And we don't have a really good assay to test for growth hormone in the serum. So we test for IGF-1 as well, right? That's a common question. If you suspect a growth hormone abnormality, don't check their growth hormone level. It's very hard to do that and very unreliable. So we check their IGF-1 as well. You can have the opposite problem where we're making too much growth hormone. So in kids, it's called gigantism. In adults, it's called acromegaly. You can see enlargement of their bones, enlargement of their organs, enlargement of their tongue. It's all the widening of the space in between the teeth, right? You can take a look at if they're an adult, right? You look at their ID, their driver's license picture compared to now, and their face might look different, right? It might look enlarged. Their hat size might increase, right? And then growth hormone makes you insulin resistant, so they might have new type 2 diabetes or elevated blood glucose. In that case, right, if they have an elevated growth hormone level, the primary treatment for that is going to be a transsphenoidal resection. For elevated growth hormone, if we do a brain MRI and we see the suprasellar mass in the pituitary, we like to remove it surgically. If it's a prolactinoma, we tend to approach it pharmacotherapy-wise, right, with cabergoline or bromocriptine first, which are dopamine antagonists. I'll talk about that more in my endocrine lecture coming up this week. So those are kind of the approaches there. This patient has a suprasellar mass that is causing compression and decreasing the production of growth hormone. So this kid, right, the most common cause of a suprasellar mass in a kid is going to be a craniopharyngioma. So that's most likely what this kid has. All right. And two more. 62-year-old woman with a 30-pack year smoking history presents with polyuria, polydipsia, constipation, fatigue, and confusion over 3 weeks. She was diagnosed with squamous cell carcinoma of the lung 2 months ago. Her calcium is elevated at 13.4. Phosphate is low at 1.8. The BNP is otherwise normal. Why does this patient have hypercalcemia? Take a second, pause your screen, and think about it. So this patient has production of PTHRP, parathyroid related peptide. So basically what this does is it acts just like PTH, except it doesn't have any effect on vitamin D. So real quick, parathyroid, right? We have 4 parathyroid glands kind of behind my thyroid. They have these CGRPs that sense calcium levels, right? So when calcium is normal or elevated, the calcium feeds back, binds to the CGRPs and decreases PTH production. When that calcium starts to dip, the PTH gets increased. It goes down to the osteoclast and it activates osteoclast. So we chew up the bone and we increase calcium and phosphate. It goes down to the kidney and it upregulates 1-alpha hydroxylase, which takes 25 OHD that is stored in my liver, throws it through that enzyme, and then that enzyme converts it to 125 OHD, which is the now metabolically active form of vitamin D, which is steroid hormone, goes to the gut, and at the level of gene transcription increases the intestinal absorption of calcium. And then also parathyroid, or parathyroid hormone, goes to in the kidney, in the proximal convoluted tubule. It blocks reabsorption of phosphate, so we pee out phosphate. And in the distal convoluted tubule, it helps us reabsorb calcium. So all in all, we increase calcium, decrease phosphate. PTHRP does the same thing, but again, it has no effect on that 1-alpha hydroxylase, so we don't really impact vitamin D. But again, it's going to increase calcium, decrease phosphate. Squamous cell carcinoma of the lung and renal cell carcinoma tend to be the two most common causes of PTHRP. Okay, so whenever they ask about a patient who has a smoking history, who now might have a cancer and they have an elevated calcium, that's the most likely what they're getting at. Other causes of hypercalcemia of malignancy, right? PTHRP is one of them. The other one would be your multiple myeloma, which is an IL-1 activating factor, which is also called osteoclast activating factor. IL-1 activates osteoclast, so we chew up bone, increase calcium, right? And then the other mechanism is increased production of 1-alpha hydroxylase in these, usually in like granulomatous formation, right? So you probably remember that from sarcoidosis, TB, Crohn's, histoplasmosis, borreliosis, right? But those aren't examples of cancer. So cancers that can upregulate 1-alpha hydroxylase would be things like lymphomas, okay? I think those are what I want to say there, right? Symptoms of hypercalcemia: stones, bones, groans, psychiatric overtone, right? So kidney stones, bone pain, constipation, GERD, brain fog, depression, right? Increased calcium, we can treat. The first step is always give them IV fluids. And then if that, after you do that, you can give them calcitonin, which suppresses osteoclast function now, but it only works for a short period of time. And then we can give them bisphosphonates, which cause osteoclast apoptosis, which take about 48 to 72 hours to kind of kick in, but they work for a much longer period of time. And if none of that works, right, we can potentially give diuretics, and then we can do dialysis. Hypercalcemia also shortens your QT, whereas hypocalcemia prolongs your QT. And then remember, with hypocalcemia, we can have tetany. We can see Chvostek's sign, where you tap their facial nerve and they get a jaw jerk. We can put a blood pressure cuff around the brachial artery, and the patient can have Trousseau sign, where their wrists flex. And then hypocalcemia can cause perioral numbness and tingling, also in the fingers and toes. All right, and last one. 44-year-old woman presents with central obesity, moon facies, buffalo hump, and purple striae. She has hypertension and was recently diagnosed with type 2 diabetes. She denies taking any steroids. 24-hour urinary free cortisol is markedly elevated. Serum cortisol is not suppressed by low dose 1 milligram dexamethasone. The ACTH is elevated, and then the high dose dexamethasone suppresses cortisol by 60%. So what is the most likely source of excess ACTH in this patient? Pause your screen and consider. So this patient has what we call hypercortisolism. We got to figure out why and from where, right? When I think about hypercortisolism, right, it's all the signs and symptoms we see in this vignette, right? Because cortisol has a myriad of functions, right? It can cause excess fat deposition. It can cause hyperglycemia. It can cause elevated blood pressure, immunosuppression, osteoporosis, cataracts, glaucoma, so many things it does, right? So these patients often present with excess weight gain, right? Elevated blood glucose. Maybe they have depression, right? Cortisol can absolutely mess with mental function. It can cause depression. It can cause psychosis, right? And so what we do when we suspect hypercortisolism, we have to document the hypercortisolism, right? So we have three major tests we can do: the midnight urinary, or the midnight salivary cortisol, okay? Because around midnight, cortisol should be pretty low, okay? And it peaks early morning. We can do 24-hour urinary cortisol, or we can do the dexamethasone suppression test, okay? Usually we like to see 2 out of the 3 be documented as elevated, and then we can be pretty certain this patient has hypercortisolism. So once they have documented hypercortisolism, like they have here, we need to figure out, is it ACTH dependent or ACTH independent, right? Examples of ACTH dependent would be Cushing disease, which is a pituitary adenoma in the anterior pituitary that's actually secreting ACTH. And then we also have ectopic ACTH production, right? You're probably most familiar with small cell lung cancer. Carcinoid tumor of the lung also can secrete ACTH, right? So that ACTH goes down to the zona fasciculata, increases the production of cortisol. That cortisol will do all of its things. It'll also feed back and shut down the production of ACTH. The problem is if you have a tumor in your pituitary or a tumor ectopically that's kind of playing by the rules of its own drum, right? That ACTH is still going to be either normal or even elevated. And again, we've talked about this. It's abnormally normal. If the cortisol is super high, the ACTH should be undetectable. So even if the ACTH is within normal limits, you're like, there must be another source of or there must be something that's making too much ACTH out there, right? And then we got to figure out what. In that case, right, you could do a brain MRI, or you could do a chest X-ray or chest CT, kind of depending on where they give you in the vignette or what your patient's telling you, right? If they have a many pack year smoking history, I probably start with the chest X-ray or the CT. If they have a history of headache and bitemporal hemianopsia, right, the pituitary sits right on top of the optic chiasm where my optic nerves cross over, right? We'll talk about this more in neuro. But if you have a tumor compressing that optic chiasm, we often lose the bilateral sensation or bilateral visual fields, right? So that's another classical sign of a pituitary mass. So then in that case, you might want to start with a brain MRI. If the patient has hypercortisolism, but their ACTH is low, right, then in that case, it's probably coming from their adrenal glands, right? Because in this case, the elevated cortisol is made from their adrenal glands and will feed back and shut down ACTH, okay? Or the patient is taking exogenous cortisol, right? They're taking exogenous steroids. And so in this case, right, we see the ACTH is elevated, all right? So that kind of narrows it down. And in this case, right, pituitary corticotroph adenoma would be the most common answer, because we gave them a low dose dexamethasone, which doesn't do anything, right? In someone who has excess ACTH being produced, usually low dose dexamethasone is not going to suppress ACTH. But if we give a high enough dose of dexamethasone, if it's a pituitary tumor, it is still within my HPA axis, hypothalamus pituitary adrenal axis, right? So it still has to play by the rules of the HPA axis. So if I give them a high enough dose of dexamethasone, an exogenous glucocorticoid, it has to play by the rules that exogenous glucocorticoid feeds back and shuts down ACTH. But now think about it. If we had an ectopic source of ACTH, like small cell lung cancer, right, it's outside of the HPA axis. So even if I give a high dose dexamethasone, this tumor is like, I don't play by your rules. I'm not suppressing. I'm going to keep secreting this ACTH. So we found out this patient has hypercortisolism, that's ACTH dependent. So again, it's either from the pituitary or from an ectopic source. And then we gave a high dose dexamethasone that suppressed the ACTH production, right? Normally, to consider it a positive test, if the dexamethasone suppresses the ACTH by more than 50%, in this case it was 60%, we consider that a positive test, or it's suppression of the ACTH. So because the ACTH suppressed with high dose dexamethasone, we can be more certain that it's probably coming from the pituitary, right, or from the brain, right, rather than an ectopic source. All right, that is what I want to stop with. Sorry about the PowerPoint kind of cutting in and out. I don't know what that was about, but hopefully you got a lot out of this. I'll try to do one or two more endocrine ones before my big lecture. Reach out if you have any questions. Until next time, all right?